Joining me today is Dr. Margaret Terharn. She's a breast cancer surgeon at Comprehensive Cancer Centers of Nevada, and she's the medical director of the Breast Cancer Center at Sunrise Hospital. Thanks for coming on the show.
Good morning, Michael. Thank you.
So how did you become interested in breast diseases?
So my training is as a general surgeon. So breast surgery was part of that, along with appendixes, gallbladders, all kinds of abdominal surgeries, etc. When I first went into practice, I joined a group that was 4 men and me. So when women were referred to the group with breast problems, they usually wanted to see the woman doctor. So that's how I got started. There really weren't any specialty training programs available in breast disease at that point. So sort of on-the-job training. But it was so rewarding that I decided to specialize in it.
So did this trajectory happen once you arrived in Las Vegas? Because before you were in Ohio, correct?
Correct. Prior to that, once again, because I was the woman in the large group, I'd say 80% of my practice was breast. And so when I came to Las Vegas, that's when I decided to focus exclusively on breast surgery.
So what's a typical day like for you, or week rather?
So Monday, Tuesday, and Thursdays, I'm in my office up the road here and see patients usually during the day. Some people are, usually, all through the day. Some of the patients, and in fact, the vast majority of them do not have cancer. They have other problems. Perhaps their mammograms are abnormal. We have to kind of figure that out. If they have infections, I'll see that. There's other problems, benign lumps that I deal with as well. So the cancer part of it is a big part of it, but still not the only thing that I do. So that's Monday, Tuesday, and Thursday, and then Wednesday and Friday I do my surgeries.
Okay.
And those are mostly breast cancer procedures.
And how long can those tend to last for you?
So, a simple procedure can take an hour to an hour and a half. The more complex ones, 4 hours, maybe a little more.
Have those gotten shorter over time in general, just in terms of breast cancer surgeries as a whole?
So because the majority of breast cancer surgeries are not really extensive surgeries, they're just kind of local removal of problems, they are much briefer than they used to be in that regard. Plus, a little experience over time has kind of shortened the amount of time it takes to do them as well.
Right. So what do breast cancer rates currently look like? Are we experiencing more cases as a whole? And then what are the outcomes looking like compared to when you started, maybe?
So in 2017, there's expected to be in the U.S. 250,000 women that are diagnosed with breast cancer. Since the year 2000, the rates have gone down in terms of the numbers of breast cancers that are being diagnosed. So we're making improvements in that regard. In terms of the outcomes, once again, that's also improving, especially for the women between the ages of 40 and 50. They are doing better in terms of their long-term survival. So we're making strides.
Why do we think we're experiencing fewer cases of breast cancer? Why are those numbers going down?
I'm sure that's multifactorial. Some of the ones would probably be increased awareness. There's been a lot of, push to make sure that people are aware that they need to be sort of surveilling their breasts and keeping an eye on things themselves. Screening's improved in terms of our ability to use mammograms and to get good information from them. One of the things that did happen around 2000 is that there was a study called the Women's Health Initiative that showed that taking hormone replacement for a prolonged period of time after a menopause could increase your risk for getting breast cancer. And so that's less commonly done since that study's come out, and that's probably been another contributor.
Wow. What was the mechanism that drove that in the study in terms of why are those two things linked?
That actually was kind of a secondary endpoint of the study. The main focus was that they thought that estrogen was something that would decrease your rate of heart attack or stroke or something like that if you took it after menopause. So that was the original premise for the study. And they actually found out that that wasn't the case. But in addition, what's the rate of breast cancer was one of the additional questions they were asking. And so, like I said, it was kind of not quite serendipity, but not their main focus of doing that study in the first place.
Right. What are some of the biggest advances you've seen over your career?
So from a surgery standpoint, we are able to do less surgery and still accomplish the same survival long term. So when I first started into practice, we had just barely gotten past the radical mastectomy stage for everybody that had breast cancer. So that meant taking off not just the breast, but the underlying muscle and a bunch of tissue under the arm. So, and that was real disfiguring and had a lot of long-term complications. And so some of the thought leaders had come up with, okay, maybe less extensive. If you're still going to do a mastectomy, leave the muscle, don't take as much under the arm. That was being accepted. And it was pretty much accepted by the time I got to practice. It was just starting to become accepted and proven that it was just as effective to remove just the tumor as opposed to taking off the whole breast. So that part's become even more advanced since that time. What's really better in terms of breast cancer care is that we're able to focus and to sort of streamline our care to individualize it in terms of the additional treatments that are needed after the surgery, in terms of maybe chemotherapy, endocrine therapy, radiation therapy. So that's made leaps and bounds of progress.
What's not that there's an average case, but what is the most typical case you tend to see? What do you do? And then what are some of those things that you do after the fact, those treatments?
So breast cancer is a broad term for a lot of diseases. The most common kind of cancer that I see is called invasive ductal cancer. The breast cancers tend to originate, in fact, 90% of them come from the milk glands in the breast, and the ducts are the tubes that take the milk out to the surface. So 80% of those cancers are the ductal cancers. So that's the most common kind of breast cancer. But in that category, there's also several additional categories. But as far as being what I see most often, that is the type of cancer that I see.
And so what's your course of action if someone comes in?
So it's dependent on a lot of things, the size of the tumor, or whether I can tell if there's any lymph nodes that are involved. If breast cancer is going to leave its original site in the breast, the first place it's likely to go is to the lymph nodes under the same arm. So that will make a difference as to what the treatment is. If there's any evidence that the cancer spread beyond that, and we certainly like to find it way before it gets there, but it's likely to go maybe to liver, bones, lungs, something like that. So that also is something that would make a difference as to what the next step would be. Hopefully what we're finding is something that's a small tumor, perhaps found by mammogram or by someone's self-exam when it's a really small tumor. And in that case, I can usually just remove the tumor and check the lymph nodes, because sometimes when the cancer spreads, it does so in microscopic amounts, and so the lymph node actually has to be removed to know if it's in there. And once again, that makes a difference in terms of what the next step's going to be in the patient's treatment. So that's why we need to check those things, and that's my usual fairly brief hour to an hour and a half surgery to get that information. Once again, there are things called receptors that we check on the cells, estrogen receptor, progesterone receptor, HER2 receptor, and in some situations, depending on what that combination is, at the size of the tumor, whether the lymph nodes are involved, sometimes other treatment is recommended for patients before they have surgery. Certainly in a HER2 positive tumor that's fairly large, having chemotherapy before having surgery is often recommended.
And that just shrinks it, so there's...
Shrinks it, and in some cases, depending, actually can make it go away. We don't really necessarily know that until we take the area out where the original biopsy was done. But the newer HER2 treatments are actually in 80% making the cancer go away. So.
Oh, wow. You're listening to Nevada Health on KUNV. We're talking to Dr. Margaret Terhar about breast cancer. Can you talk to us a little bit about how to understand the stages of breast cancer? So, if you're the average person and you hear, well, this person has stage 1, this person has stage 2, this stage 3, stage 4, what does that really mean?
Well, basically it allows us to sort of get an idea of what the prognosis is going to be. So there actually is a stage 0. And when breast cancer is discovered before it's developed the ability to invade into neighboring cells and spread other places, then it's a stage 0. So the first invasive cancer, and that's why, invading into the cells and having the ability to spread, it means you have an invasive cancer. So if your invasive cancer is less than 2 centimeters and there's no evidence that it spread to the lymph nodes, then it's a stage 1. If it's larger, up to 5 centimeters, and perhaps there is some evidence that the lymph node might be involved, then you're talking stage 2. Larger tumor, but still contained within the breast and lymph nodes, would be stage 3.
So the danger of it spreading into the lymph nodes, is it almost acts as like a shuttling point that it could go to other areas of the body?
Yeah, exactly. So lymph nodes are not just useful in our bodies for taking care of cancer, but it's something that they are part of our immune system, so they deal with infections and inflammatory responses and that sort of thing. So a sort of simplistic way of thinking it is that they sort of act like filters. So if your breast cancer has gotten into a lymphatic channel, which is a little, fluid that goes through the breast tissue. If it's gotten in there, then it's going to kind of take that liquid highway up to the lymph node under the arm, which is then going to grab it and hang on to it and try to keep it from getting elsewhere. And so that's why we check those lymph nodes, because that is sort of the first way we see that there's something that's gotten beyond the breast.
Where are the most common areas it spreads to past the lymph nodes?
The lung, the liver, and the bones. In some cases, depending on the aggressiveness of the tumor, sometimes brain metastasis can happen as well.
Wow. Yeah, that's another word you hear. It's, I have an aggressive tumor, or my tumor isn't as aggressive. What does that really mean?
So it tends to be based on a couple of things. One is something we call the grade of the tumor. And so the grade basically tells you what the tumor looks like under the microscope when the pathologist looks at it. And so a grade 1 tumor tends to not look as different from a normal cell as, say, a grade 3 tumor. And then there's a grade 2 in between. So the further up the grading scale you go is sort of a loose correlation with how aggressively the tumor behaves.
Interesting.
Also, the other things, as we discussed, the receptors can tell us whether the tumor tends to be aggressive. The HER2 positive tumors tend to behave aggressively. The triple negative tumors also tend to behave aggressively. And so that's one of the things that helps us to decide, how aggressively we need to respond to it.
And talking about those hormones, so when you hear HER2 and triple negative, what's the difference between those?
So when we check receptors on a breast cancer, we check the three, which are estrogen receptor, progesterone receptor, and those are what we call the hormone receptors. And then this HER2 receptor, which is more of a protein expression. So all of our cells in our body express this HER2 protein, but if your breast cancer does what we call overexpress it. If there's an excess amount of it in your breast cancer, then that makes it a HER2 positive tumor.
And those tend to be more aggressive.
Correct.
Why would someone get a HER2 positive tumor and someone get a HER2 negative tumor? Do we know?
So in terms of HER2, there really isn't anything that's, it's just random. It's not anything that we know, okay, you're more likely to get a HER2 positive tumor. In terms of triple negative tumors, there are folks that are more likely to get them, and those are those who have some genetic changes. The BRCA1 tumors tend to be triple negative. So that's something that you can sort of predict on that basis.
Yeah. How much of an influence does genetics play in breast cancer?
So 85% of breast cancer is totally sporadic. It's random. You didn't do anything wrong. The number 1 and 2 risk factors for getting breast cancer are being female and getting older. Can't do anything about that. So, there's nothing you can do except for try to be on top of, if you're going to get it, getting it when it's early. That other 15%, there are some that are genetically mediated, some that we call familial. So if you do have a strong family history, you should have your genetics checked, but there's still a situation where your risk might be increased just on the base that your family has a lot of breast cancer in it.
You mentioned screening. So what are the typical guidelines now?
So it depends, and there's been a lot of controversy about that, as I'm sure you're aware, because you're obviously very up on this stuff. But the idea is that you're going to catch the cancer before it's had a chance to manifest itself outwardly. And so mammogram is still the number 1 way of doing that. There are other studies that can be used as adjuncts to mammography, but still it's the gold standard. It's what we can get the most reliable information for the most number of people from. So we also recommend that people, that they examine their breasts themselves. There is some controversy about that as well. Everybody feels their breasts are lumpy, and I tell my patients, don't put a lot of pressure on yourself. You're not going to be an expert, and you're not supposed to be. You're only supposed to sort of get a feel for what your own breasts feel like, so that if there was something that changed, you would be able to notice that was the case. So.
Yeah. How often do you recommend people get mammograms?
So I'm still with the starting at age 40, doing it annually if you are at average risk. I think you should do it until you health is so bad that if you were discovered to have a breast cancer, you wouldn't tolerate the treatment for it. And
Yeah.
treatment for an early breast cancer is really well tolerated. So
Explain kind of what the recovery looks like. Like, how long does it take to recover from that? And
So it really kind of depends on what the surgery is that I do recovery-wise. The majority of the people with an early stage breast cancer who just have the tumor removed and or lymph nodes sampled, I mean, I see them back in the office at a week, and they're usually pretty much able to get back to their normal activities at that point because the surgery's done as an outpatient, so there's not a lot of recovery time. Some people who have more physical jobs need some more time, but it's individual in terms of how quickly you get better. But that's usually a fairly representative example. Whereas people who need mastectomies, who have reconstructive surgeries, the timing is usually in weeks instead of days, but still within a month or two, you're back to your old self again.
you mentioned sort of some controversy around screenings. What is the controversy?
So basically is when does it start and how frequent should it be? Okay. Mammograms are still, regarded as the way to do screening, but should you start at age 40 if you don't have any family history of breast cancer? What should the interval be between 40 and 50? Is annually still appropriate, or should it be every 2 years? After you're 50, once again, is it every year or is it every 2 years? When do you stop? Some people say 70, cut it out. There's no reason to do it anymore. There are several reasons for that. Partly, mammograms aren't perfect, and so we can find things that are what we call false negatives, meaning we're worried about them, but they're not really a problem. And that causes anxiety, and so think, well, we can reduce anxiety by not doing mammograms on people who don't have as high a risk as others. Of course, there is the monetary factor there. Are we spending our limited healthcare dollars on something that's really bringing us benefit? And certainly, how many lives do we save? Well, if it's your life, it's worth it. If it's, if you're looking at the general statistics and it's only a small number, well, maybe economically they wouldn't see that as feasible. But I still recommend annual mammograms. I can't count, and obviously my experience is biased, but I don't even know how many people, no family history, no risk factors whatsoever between 40 and 50 who get diagnosed with breast cancer because they had a mammogram. So,
wow. What is the rate of those false positives? What would be called in the test?
So false positives aren't very common. It's the false negatives
false
that
negatives,
we're talking
yeah,
about, and I honestly don't know what the statistic is for that.
How does lifestyle affect? I mean, you said mostly 85% of cases are just being a woman and time.
Getting older, yeah.
Yeah. How does lifestyle impact breast cancer? Is it not as important as it might be in a lot of other cancers?
So there are some other risk factors that can be accounted that obviously aren't as strong as these. The third most strong risk factor would be your family history. So it's important, and especially in prior generations, people didn't tend to talk about, whether or not they'd been treated for breast cancer. A lot of women felt that was not ladylike to talk about, or that it was, personal and they didn't want to share it. But it is really important. So talking to your predecessors and finding out what your family history is really important. Some other things like smoking. Smoking is a risk factor. Women who smoke are more likely to get breast cancer than those who don't. It's not got the same sort of cause and effect like with lung cancer, but there is definite evidence that that's a risk factor, so something to consider. Diet in terms of keeping your weight as close to normal as possible is important. The increased estrogen from the adipose cells does increase the risk for breast cancer, so that is another thing that is considered to be a risk factor as well.
Walk us through how chemo works and how radiation works. Why are you using one or the other, or a combination of both, and what exactly do they do?
So what I do in surgery is to treat the local situation. So the tumor starts in the breast. I work on the breast. I work on the lymph nodes. That's my contribution. Same with radiation treatments. Therefore, the majority of the time in an early breast cancer, just to control the situation, make sure the cancer doesn't come back locally. Chemotherapy, endocrine therapy are whole body treatments. So they're kind of recommended when you need to protect the rest of the body, not including the breast, but also, the liver, the lungs, the other places where you're kind of trying to keep the cancer from having the opportunity to kind of set up shop elsewhere.
Interesting. So radiation works. It's just because these high energy rays theoretically come in. You've taken out the tumor. There might be something left.
Yeah, the idea is when we do surgery for breast cancer, we want to have what's called negative margins, meaning that we have not cut across tumor, taking out whatever it is that we're taking out, because the potential for having left significant disease behind is high enough that we need to make sure we get those negative margins. But even in the situations where the pathologists tell us, you got clear tissue all the way around, there's still the possibility there could be some microscopic cells that got left behind. And so that is what the radiation's for, is to make sure that those don't have the opportunity to cause a new tumor. In some situations, depending on which studies, there's like a 20 to 40% chance your tumor will come back if you just have it removed and don't have radiation. So it's definitely a good thing to do in situations where the radiation's there. Usually the risk is reduced to less than 10%. So.
Oh, wow. So that's pretty significant.
It is.
And so chemo, the idea is that maybe some of these cells have migrated. There's just a few.
Correct.
We don't want them to end up somewhere else. So chemo kind of just says, if they're somewhere, this will hopefully get them.
Exactly true.
Interesting. How long does it take a tumor to grow? Like, when do these things start?
Yeah, so, it's just a normal cell just mutates. And depending on what kind of cancer it is and the different factors, grade and the receptor status, that sort of thing really influences the rate at which the mutation or the continued growth of the tumor will progress, how fast it will progress. So
Interesting.
it's not one of them. It's like today it's going to be here, and in a year it's going to be this big, and in 2 years it's going to be that big. You can't really tell.
Interesting.
Just generally.
Do some types evolve over years, and others could develop in, say, 6 months or something?
Exactly true.
Interesting. So those ones that develop in, say, 6 months are going to be probably a little more dangerous than others.
The ones that are more likely to go other places, that's where we don't cure anymore.
Interesting. How? So let's say someone gets a diagnosis. What are the first things you tell them?
So we discuss the pathology report in detail. The things that I told you, is it invasive ductal cancer or some other type? What's the hormone receptor status? Reviewing of the x-rays they've had before, usually a mammogram and or an ultrasound. Some people have MRIs before they come. Just going over those particular findings, recommending any additional testing. Do you have this strong family history? Should you have genetic testing before we decide what the next step's going to be? Do you need any additional imaging? Do you have the situation where you need to probably speak to the medical oncologist before I operate on you? That's the sort of thing that I advise the patients on. They also want more information than I can give them when I sit down. And also, your brain's kind of on the fritz when you find out you have cancer. So it's really hard to sort of assimilate a lot of the things that I'm trying to tell them. So, I'll send them to the internet if they're, interested. You can't believe everything you read on the internet. I know that's news to you, but there are more reliable websites than others. So I try to send them to the ones that are more reliable. If they're not internet savvy, there are some places where you can actually get information in the community, and one of which is the American Cancer Society has several satellites around the valley, and there's actually one up just the road here on Maryland on the Sunrise campus. So they have full-time employees that will help people navigate through these things. At the Breast Center at Sunrise, we also have a nurse navigator that is someone that will help not just with, information, but with support and with, other things that the patients will need to kind of help them guide through their journey. So,
what questions should patients ask their doctor if they get a diagnosis?
Just basically, what exactly do I have? What's your treatment plan? What are the alternatives to this treatment plan? Which I try to present, what all the alternatives are when I have my initial discussion with them. What am I expecting in terms of additional treatment after the surgery? Do I need chemotherapy? Do I need radiation? When are you going to send me for those referrals? That sort of thing.
Mm-hmm. What questions should maybe family members be asking the patient?
So how can I be supportive is the biggest thing. There's a lot of different cultural and, sort of gender different ways of dealing with things. Men tend to, especially if their wives are involved, want to fix things, and this isn't something they can fix, so they can get really frustrated. So they just kind of need to know that being supportive of this woman as she goes through her process, and even if she's doing something you think's kind of dumb, just kind of let her do it, because this is how she's coping, and everybody has different coping mechanisms. So.
Yeah, it's sort of her journey. What are some of the best resources? You mentioned a couple in the community if you get a diagnosis, because I'd imagine it's a lot of psychological weight. Right?
There are several of the places that I'm aware of. The caring place that is in here in town, Susan Komen, has some information. There are some psychologists that specialize in cancer stressors, and so we have information about that. But
what are some of the, I guess, most interesting things you see at the hospital in terms of like inspiring things?
Well, everybody's journey is different, and when I see the 24-year-old who's told she has breast cancer, I mean that's an old lady disease. You're not supposed to have that. So to watch her come out on the other side a stronger, usually more mature person, that's very inspiring. The women that are single moms, the women that are, business people that have a lot of folks depending on them in terms of being able to, cause the others that support people to be able to earn their livings. They're all, each one of them, and there's not anybody that doesn't have an inspiring story. It's just a matter of, how does it appear to you? But everybody's got to walk that walk, and it's not an easy road for anyone. So.
Yeah. How can people from the community support breast cancer?
So several ways. I mean, obviously, helping to raise awareness is what we're doing here today, and that's knowing that there are good places in town to get the sort of treatment that you need, the sort of screening that you need. Those are those things that are important. There are support areas, that we can also support systems like the American Cancer Society, Susan Komen, those sort of people that'll help us with that.
In terms of, let's say, donating to research, are there certain outlets that you like?
So once again, Komen is somebody that is not only to research, but also to supporting the people that have been diagnosed. There are a lot of programs out there for breast cancer research. The ones that are mostly affiliated with universities are the ones that I would probably say would be somewhere where you would reliably spend your money.
If there was just one thing you would want people to know about breast cancer, what would it be?
If you find it early, we're going to cure it.
Perfect. Well, Dr. Terhar, thanks so much for coming on the show.
My pleasure.